Welcome you all to our regular weekly session on oncology. So in the era of this COVID, we have been trying to keep ourselves busy in doing some academic practice. And as a part of that, we have been running a weekly program on oncology. How should I treat my patients following evidence-based medicine? Now, we are running the colorectal series. And today, our topic is oligometastatic colorectal cancer, how to deal. Our today's presenter is Dr. Sadeka Sultana, who is a brilliant oncologist of our country, and she is working as a specialist in the radiation oncology department of United Hospital. And today we are having two overseas faculty. Zahid Khan, a very known name by now. He is a graduate from Chittagong Medical College, now working as a medical oncologist, consultant medical oncologist in Clatterbridge Cancer Center, Liverpool, UK. And today we have a new guest, Dr. Tarek Abdullah. He's a consultant clinical oncologist in Beeston, west of Scotland Cancer Center, UK. And he is a graduate from Dhaka Medical College and now working as a consultant there. And as per custom, we always start with our president and patron, Professor Emir Haisar, who is also the patron of SARC Federation of Oncologists. So I will request Professor Emir Haisar to start formally our session.
Bismillahirrahmanirrahim. Thank you, Kamal. Today we have two bright stars of Bangladesh. They will be blinking and throwing light towards us from UK. And our presenter is Dr. Sadeka Sultana. Our today's subject is oligometastatic colorectal cancer. Without any further delay, I welcome you all, and thanks to all of you. Please start without any delay.
So Sadeka, can you please start?
Okay, sir. Assalamu alaikum. I am Dr. Sadeka Sultan Ahmed, working as a specialist at United Hospital Limited. Warm welcome to everyone in my today's presentation, as my topic is oligometastatic colorectal cancer, how to deal. (25 to 35% of patients present with synchronous metastasis. 50 to 60% of patients will eventually develop metastasis, mostly within 2 years of detecting the primary. 5-year survival is 2% if unresectable and 50% if resectable. First, we have to understand oligometastatic disease before we speak about the right treatment. If we look to the local treatment and intent is cure, in metastatic disease, two different treatment goal. Diffuse metastatic disease, treatment goal is truly palliation. Patient groups for oligometastatic disease, patients were prognostically in between cure in terms of overall survival and progression-free survival, and in some way, palliative incurable disease. These groups of patients we are putting in chronic disease or potentially curable group of patients for which we need local treatment. There is a relationship between tumor burden and prognosis of patient. We have learned this concept in treatment of metastatic colorectal cancer with systemic chemotherapy. This concept is theoretical concept, but there is a mathematical mechanistical hypothesis which shows that there is a relationship between tumor burden and depthness of response or extent of tumor burden, upon which patient's overall prognosis depends. General say of hypothesis, more tumor shrinkage, less tumor burden, so we have better overall survival. If we look to the biology, we have other concept. The Goldie-Coleman hypothesis says that we have large amount of tumor cell, then resistant tumor cell clone development will be higher. But if we have limited number of metastatic tumor cell, resistant tumor cell clone will be less. From local tumor to oligometastasis to diffuse mets, then to terminal disease, we have a continuum over time. Every patient from local disease will develop oligometastatic disease to diffuse mets, ultimately to terminal disease if we do nothing or just wait. This concept depicts that tumor biology have a continuum over time. that published many years ago in 1898. However, we have learned other factors contributing, for example, biological factor, which will modify the tumor, will modify the disease, for example, the evolutionary process of metastasization. For better understanding of biology of tumor, allows us to say maybe there is a shift in the biology, not some same biology from local tumor can overturn to terminal disease. So metastasization need a new tumor biology to develop diffuse metastatic disease. In oligometastatic disease, we have less oligometastatic disease, tumor cell may not actively migrate. So local tumor control is good. Tumor cell sites remains at site, so target organ become inhospitable. But in case of disseminated disease, tumor cell migrate actively, so tumor control poor, tumor cell will not remain inside, target organ become inhospitable. So there is a change in biology which discriminates between localized metastasization and widespread metastasization. There is a CMS classification, which includes CMS type 1 immune, type 2 canonical, type 3 metabolic, type 4 mesenchymal. In case of right colon, maximum percentage was CMS type 1 immune. And in left colon and rectum, maximum percentage shows canonical. CMS classification gives us different information in terms of relapse-free survival. CMS type 4 mesenchymal has the worse prognosis. And if we look to other prognostic information in terms of survival after relapse, we'll say course of metastasization CMS type 4 not so bad, but CMS type 1 immune is worse. So we have different pattern of predicting relapse and different pattern of predicting prognosis of relapse. In future, we have prognostic predictive information from biology, and maybe molecular subtypes allows us to select immunotherapy. There are other types, canonical with 33% frequency and in intermediate overall survival, immune type 28% frequency with favorable, and stromal 39% and unfavorable prognosis, overall survival. Oligometastatic can be defined by Holman and Baum postulated the existence of an interim stage between limited local disease that can be cured by local treatment and disseminated, generally incurable disease. Oligometastatic state suggests a clinical situation in which local treatment is accompanied by an improved prognosis ranging from local progression-free survival to improved overall survival. According to ESMO consensus guideline, oligometastasis disease can be characterized by the existence of metastasis at up to 2 or occasionally 3 sites and 5 or sometimes more lesions, predominantly visceral and occasionally lymphnodal. Typically, these are the primary and other involved sites such as the liver, lung, peritoneum, nodes, and ovary. Oligometastatic disease can also be defined and by the localizations of the disease and use of local ablative approaches. According to Palma et al. Showed that radical treatment of oligometastatic disease leads to an improvement in both disease-free survival and overall survival. This phase 2 trial in patients with a variety of solid tumor are demonstrated that radical treatment of oligometastatic, which used stereotactic body radiotherapy, resulted in an improved overall survival compared with standard treatment, palliative radiotherapy, the standard systemic treatment. Median overall survival in SBRT arm was 41 months and in control arm is 28 months. If we have favorable prognostic factors such as single lesion, metachronous metastatic disease, long disease-free interval, response to systemic treatment, then there is a more likely to chance beneficial from local treatment. But if we have unfavorable prognostic factors like numerous metastasis, synchronous metastatic disease, short disease-free interval, progression during systemic treatment, there will be less likely to be beneficial from local treatment. There are other modalities for oligometastatic disease such local ablative therapy, SBRT or RFA. Different and trial shows that there is very good local control. Randomized phase 2 clock trial enrolled about 119 patients, liver mets only, between the chemotherapy versus local chemotherapy plus ablative treatment. This trial showed better overall survival in combined modality treatment option. ESMO consensus guideline shows base treatment is to be decided on the pattern of metastatic disease and availability of methods. So depending upon situation, all of the treatment modalities can be used for local destructions of the tumor. It's include some thermal device, radiofrequency ablation or cryoablation, microwave ablation, non-thermal device brachytherapy, electroporation, or transarterial radioembolization. Radioembolization used as embolic device, selective internal radiotherapy, transarterial chemoembolization, or local chemotherapy. Local ablative treatment should be selected according to localization, treatment goal, treatment-related morbidity, local expertise and availability, patient-related factor. For patient with oligometastatic disease, systemic therapy is the standard of care and should be considered as the initial part of every treatment strategy, except patients with single or few liver or lung lesions. Local ablative therapy can be used as a primary or metastatic specific treatment to halt further dissemination. This could delay or even eliminate the need for systemic treatment. Local ablative therapy can also be used following systemic therapy as a consolidative treatment to delay or halt further treatment. This can be done in place of surgery, especially in prognostically unclear situations or after response to systemic treatment. In more widespread disease, local ablative therapy may be considered in oligoprogressive disease, that is very limited recurrence or non-response in a patient receiving systemic treatment. Such oligometastatic disease would be constituted as a result of intratumoral heterogeneity. The aim of local ablative therapy is to eliminate the cell clones no longer responding to treatment to enable the otherwise still working systemic therapy. We have learned about different patterns, so they have ends up to different treatment modalities. For example, in clock trial, we used RFA along with systemic therapy for incurable disease, and in epoch trial, used resection plus chemotherapy for curable situation. These patterns of relapse show some similarity. Recurrence occurs in an average 65% of patients, whatever the treatment modalities. Shows local relapse in case of 6% patients, systemic or extrahepatic relapse seen in 50 to 55% of patients. This clearly shows local control is good, but problem remains the systemic relapse. Treatment modalities include surgery. For patients with resectable oligometastatic disease confined to a single organ, frequently liver or lung, and or a few
সাদেকে আমরা শুনতে পাচ্ছি না।
স্যার এখন শুনতে পাচ্ছেন?
হ্যাঁ, ওকে শোনা যাচ্ছে।
Localized non-surgical local ablative therapy may become relevant in combinations with systemic therapy following a careful multidisciplinary team discussion and assessment. Should we use systemic treatment in oligometastatic disease? ESMO guideline says yes, of course we can use systemic treatment along with local ablative therapy, and evaluation should be done in between 6 to 8 weeks, which is the high time for response. Then we can use the best local treatment. Radiofrequency ablation is an example of strictly local treatment, a commonly used alternative to surgery for liver lesions, and also an option for lung lesions. The use of RFA is determined by size, usually less than 3 centimeters, and its location not so close to vascular structures, and the number of metastases. SBRT involves an ablative dose of radiation to an isolated site, leading to localized tumor necrosis and death. Developed in early 90s, ablative dose can now be delivered via standard linear accelerator or via more specialist machinery like CyberKnife. It has been used in diverse sites with varying outcomes, but most important factor is the relative lack of severe acute side effects. Most studies in the GI malignancies have been single-centered and focused on colorectal cancer. In 2018, review by Petrelli et al. Examined the role of SBRT in liver metastasis. Results suggest a local disease control rate 67% and 59.3% at 1 and 2 years, and an overall survival of 31.5 months. Nodal metastasis seems to respond well with a high local control rate. Transarterial chemoembolization and radioembolizations are a combination of a regional treatment with administrations of an active drug like fluoropyrimidine or irinotecan via the hepatic artery, with a local destructive treatment by embolizations or radiotherapy respectively, crucifer or chemoloaded beads, whereas radioembolization incorporates the delivery of yttrium-90 connected to either resin or glass particle into the hepatic artery. Management of the lung-only meds. If we suspect pulmonary metastasis, restaging studies should be done. Then we go for, is it isolated thoracic disease or is it resectable or patient is fit for surgery? If the answer is yes, then we try to understand, is it bilateral or unilateral disease? If it is bilateral disease, then stage VATS or stage thoracotomy or median sternotomy can be done. Or if it is unilateral disease and lesion size is less than 1.5 centimeter and 3 in number, if it is located in peripheral upper middle lobe involvement, then we go for physio-assistant thoracostomy. If the answer is no, then we go for non-resectable treatment, RFA, chemoradiotherapy or palliation. Or if it's not possible for VATS, then we go for thoracotomy. As per NCCN guideline, if the liver metastasis or lung metastasis synchronous or metachronous, and if it is resectable, then synchronous or staged resection of the liver or lung and or local therapy followed by systemic therapy is an option. Alternatively, neoadjuvant therapy with systemic followed by synchronous or staged resection and resection of metastatic disease followed by systemic therapy can be an option. If it is unresectable, synchronous liver or lung metastasis, then we go for systemic therapy and then reevaluate for conversion to resectable every 2 monthly. If it is resectable, then go for synchronized or staged resections of the colon and metastatic cancer, followed by systemic therapy. If it is not resectable, then go for systemic therapy. In case of metachronous and serial metachronous liver or lung metastasis, serial CE elevation or documented metastasis by CT, MRI or other physical and radiological examination, then and patient is not received previous chemotherapy, resection and local therapy the best option, followed by systemic therapy. Or otherwise, alternatively, we can use neoadjuvant chemotherapy. Then we can assess for resectability, and if it is resectable and local ablative therapy, then followed by systemic therapy also. If the patient receives previous chemotherapy, then resection and local therapy is preferred, followed by observations or systemic therapy. Or alternatively, neoadjuvant chemotherapy followed by resections and local therapy followed by systemic therapy. Surveillance can be done through his thorough history and physical examination every 3 to 6 monthly, serial examinations of CA level or imaging including CT scan, chest, abdomen and pelvis, colonoscopy every 1 yearly. If it is advanced adenoma, then repeat in 1 year, and if no advanced adenoma, then we can repeat it in 3 yearly. What can be improved in case of oligometastatic colorectal cancer? Better surgery, better local ablative treatment, better systemic treatment, and more likely selection of patient with biologically localized disease, best integration of local ablative therapy with surgery and systemic treatment, evaluations of common but not fully evaluated clinical scenarios. If we can summarize, the oligometastatic disease was initially postulated as an interim stage between local and disseminated disease. Localized treatment may lead to improvement of the overall survival and progression-free survival. Oligometastatic disease is defined as usually less than 5 sets of metastatic disease within 2 organs. Colorectal cancer offers an excellent example of malignancy that has an oligometastatic interim stage. Oligometastasis may be synchronous or metaconus. Surgical resections of colorectal liver metastasis has been shown to improve overall survival. Site of disease determines the likely outcome, with liver-only disease appearing to have the best results. There are multiple forms of ablative treatment, including RFA or SBRT. Both appear to integrate safely with systemic chemotherapy. SBRT has been shown to improve overall survival when integrated with chemotherapy. Combining ablative therapy with immunotherapy will be the next stage in developing these techniques. Thank you for patience of hearing.
Thank you, Sadeka. Now I would like to request Dr. Tarek, our overseas faculty, to make a quick comment on the presentation, then we'll go to the discussion.
The presentation is really nice and it's very elaborative, started from very theoretical and then to the clinical. There's a lot of information and Sadeka put lots of effort, there's no doubt about that. But when we come to the clinical scenario, lots of things come in the picture, particularly number of the metastases, the patient's condition, the comorbidities, and the practicality of the situation of the resources and etc. Because there's a lot of things like a saber and then type of the operation and radiofrequency ablation may not be available in all the centers. And there is another treatment which is called SART, is S-I-R-T. That's also the evidence is lacking still. So this is also another treatment for the liver mets. So, but yeah, I really like the presentation and there's a lot of effort was put in and I'm happy to discuss further.
Thanks, Pial. I see that Zahid joined us. Thanks, Zahid, sacrificing the family time and giving time to our endeavor. Any quick comment from Zahid?
Thank you, Kamal bhai. Dr. Sadeka, that was a really beautiful presentation. Thank you very much. You have covered a really good basis. There was a paper in 2020, January, Lancet Oncology, which has covered some of the basic understanding and terminology in the oligometastatic disease. If the junior trainees who want to understand better about the terms and their application, then that's a really good paper to look at too. So the first thing about oligometastatic disease is that it is always a dynamic and evolving area. I remember when I was a registrar, this liver surgeons used to say we can only operate 3 or 4 lesions as long as they're remaining on the one side of the liver, not bilobar. So there are a lot of things, and now they're saying number is not a matter. They look at the vasculature, they look at the locations, they see how much they can leave behind after hypertrophy. So there are a lot of things come into the play. So this is, and the trials that been mentioned, these are all phase 2 trials, except the liver metastasis. All the other trials are actually phase 2 trials. It's very difficult to draw any conclusion. But overall, if you ask any oncologist, how do they see an oligometastatic disease, then you'll find that we are far more optimistic and far more aggressive than we were ever before. So now if we see a limited volume disease, I will tell you the practical experience that we have an advanced colorectal MDT in our cancer center. So all these patients will go into the advanced colorectal MDT where there is a liver surgeon, there is a thoracic surgeon, there is intervention radiologists, all people are there. And they will all look at the patient information. And as Tarek Bhai said, that it's not only the disease itself, but also the patient itself. And then we'll make a plan, what is the most appropriate treatment, whether it's local therapy alone, whether it's combination with systemic therapy, in what order, in what sequence. So basically, the first thing to understand that the approach has changed. And if we see a patient with a limited volume disease, then we must consider beyond systemic treatment. That is the fundamental message.
Thank you, Zahid. As always, you try to sum up very quickly. So I try to, repeat some of the points or because Sadeka gave so many information for our juniors, let us try to focus on few areas as Tariq and Zahid was telling that it is ever evolving in the oncology. Probably the most evolving area is the oligometastasis. And I remember in 2019, the total astro was on oligometastasis. So, the total focus is on oligometastasis. And now they are telling that this is the area where we thought it was not curable. Now we are treating it curable. So this is a challenging area. So now let's, I tried to bring up some issues. So first of all, as Sadeka rightly said, that it is a new concept which was first proposed in 1995. But the interesting thing is that the surgical series as reported is 1940. So surgeons were earlier than the oncologists to describe oligometastasis. Why? Because there was a good survival. And as Sadeka mentioned, there is a classical definition given by ESMO consensus guideline where we will say oligometastasis. As Zahid was telling, the definition of oligometastasis have been changing from 3 to 5, and somebody has now been telling 8. So this is again a area where what is the size of the lesion, where the location of the lesion, all these things are the issue. And synchronous, metachronous, we all know it is the rule of 6, that within 6 and beyond 6. And in oligometastasis, we need to understand what is oligometastasis, oligoprogression, oligorecurrence, and persistence. All these terms are very relative, all are not the same. So now I start with the imaging. We know the concept of oligometastasis is evolving with the development of imaging. So in the era of X-ray, there was no story of oligometastasis. Then we started with the CT scan, and with CT scan contrast, we were quite happy. And then dual energy CT scan was providing a better image. And for brain and liver, we found that MRI is a better tool. And as Sadeka said, in the metastatic setup, when we are doing a treatment every 2 months, we need to do a follow-up imaging. So nowadays, we are very keen for FDG PET. And if we look at the evidence-based indication by use of FDG PET CT in United Kingdom 2016 publication, and they have said that FDG PET in combination with CT is the recommended in expert consensus guideline to stage colorectal oligometastasis disease. And the main advantage is in detecting extrahepatic lesions occult on CT alone. So here I stop and I want to ask both Tariq and Zahid that what is your take on the use of imaging in oligometastasis, both in ideal and also in our situation?
Shall I start? Yes, we do PET scan if we go for any local treatment, either surgery or SABR or SART or radiofrequency ablation. And we also routinely do MRI of the liver. So this is standard practice. And if preferable, is a triple phase CT scan sometime.
Tariq, message we can take that FDG PET should be done before declaring that it is a oligomets, because if we are missing something and declaring somebody a frank metastasis at a oligometastasis, that will not be a, proper justice to the patient.
Yes, one thing, Kamal Bhai, is I know that the definition is up to 5 metastases and is changing, and you probably know that the COMET SABR trial, which published, and then the new COMET, which is a COMET 10 trial is coming, and they are treating actually up to 10. So they actually went beyond 8. So if it is treatable, and if it is in different sites, and if it's treatable, is a small and compromising other organ at risk, and then it is possible to treat many. So in the UK, we do not actually fix to the idea that if it is more than 5, we'll not treat with a local treatment. I know my colleague treated 6 lung metastases with a SABR. So it's possible that we can treat more than 5. So we do PET scan. If we think that local treatment we are thinking of either surgery or radiotherapy, but it is not to look at whether it's more than 5 or not. But if it's a many, numerous, then of course not.
So after PET, is there any need of doing an MRI to rule out any small lesion in the liver, or it's enough?
Yes, this is mandatory in our center and all over the UK, I think.
I agree. In liver metastasis,
Right.
we should do a liver MRI as well as a PET for extrahepatic disease.
I mean, this is the message I wanted to share with the juniors, because sometimes in our country, you know, PET is very expensive and only few centers are doing. And sometimes we are very happy to have a PET scan image. And just today, I received a call from my radiologist. There was a PET image of a liver, of a TNBC breast cancer, suspect of a liver lesion. I sent the patient to a radiologist for a CT guided FNSC, and she said, Kamal, sir, I have seen the lesion. It is a hemangioma. PET CT was suspicious. They could not conclude. But when I have done the 3-phase CT, I found that it is not a metastasis, it is hemangioma. So this is the information that when we are suspicious about something in the liver, our best friend is not PET, our best friend is the MRI. If it is CT, it should be 3-phase CT, because in PET CT, they don't do the 3-phase CT. So sometimes they make a wrong miss, or they sometimes miss. Even for brain also, I think you will agree that sometimes PET may not be enough to give us a clue.
Yeah, Kamal bhai, for the brain mets, PET CT actually cannot give any information, because it's take all the dye in the brain because of brain's activity.
So this is why I'm telling, you know, in our country, sometimes a poor man doing a PET CT, and when I'm sitting in my clinic, in my chamber, private chamber, I'm so happy that PET CT is telling, but end of the day, there's a big surprise. I have treated a patient and the patient landed up with a brain metastasis. Then I go back, oh my God, I have not done the MRI of the brain, even it was a stage 3 lung cancer or a T3N2 breast cancer. So this is why I am bringing up this very silly but very important issues in the discussion, so that we come out of our boxes. In our country, we think the more is good, expensive is good. So expensive is not always good. Sometimes I heard from some radiologists, a good ultrasonogram is sometimes better than a PET CT for a liver lesion, because a good sonologist can make a very good comment. Yes, Zahid.
Thank you, Kamal. I'm just going to very quickly mention, since it's been raised, I mean, number of times আমার friend, relative আমাকে report পাঠিয়েছে যে যেখানে ক্যান্সার পেশেন্টদের জন্য একটা good quality CT scan ছাড়াই PET scan করা হয়েছে. And I do not understand the rationale of it. For the sake of the juniors, let's go back. What is a PET scan and what is the CT component of the PET scan? I'll just take a quick 1 minute for that. Apology for that. At a PET CT, the CT component, it is actually a low dose, thick slice CT. Remember, it's a low dose, thick slice CT. At a staging CT, 0.3 millimeter slice বা 0.5 millimeter slice CT নেওয়া হয়। আর যেটা PET CT সেখানে 10 millimeter বা তার চেয়েও বড় thick slice নেওয়া হয়। এটা কারণ হচ্ছে the idea of the CT component of a PET scan is to only to map the activity. Is only to map the activity. সুতরাং কেউ যদি PET CT কে একটা diagnostic imaging হিসেবে ধরে নেয়, is going to be a very, very big mistake. So I just wanted to keep in mind. Thank you.
Thank you, Zahid. So PET, you were telling that PET is a combination of biological imaging and functional imaging, and anatomical imaging, where the main focus is the biological imaging. Anatomy is only to locate. But if you know want to see the details of anatomy from imaging, it should be a classical CT scan or MRI, whatever it is, but it is not PET CT, because PET CT এখানে আমাদেরকে শুধু functional আপটেকটা কোন জায়গায় এটা লোকেট করার জন্য একটা খুব primitive একটা CT image এখানে দেওয়া হচ্ছে. So that is everybody is trying to bring up this issue. So juniorরা please আমরা যখন practice করব, it is better sometimes to do a CT. And look at the guideline, urological malignancy, nowhere there is any recommendation of PET CT, but randomly we are doing PET CT. There are many areas, যেমন তারেক বললো যে where there is a suspicion of brain mets, don't even do a PET CT, not even a CT, go for MRI. কারণ CT can miss some small metastasis. When there is a brain mets, straight MRI. So এই জায়গাগুলো আমাদের judicious হতে হবে. So otherwise আমরা double expenditure avoid করতে পারবো এবং আমরা miss করবো না. There is a question from Sumon, quickly. A asymptomatic patient to rule out oligo, do you suggest MRI brain plus PET combo? Answer is no. Zahid is moving his head. Pial, we agree?
I completely agree.
Okay. So quickly আমি আমার প্রেজেন্টেশনটা আবার যাচ্ছি, আমি কয়েকটা পয়েন্ট করতে চেয়েছিলাম। সো ইমেজিং এ যেটাই বলা হয়েছে যে ফাংশনাল ইমেজিং লাইক পারফিউশন, সিটি এন্ড ডাইনামিক কন্ট্রাস্ট এনহান্সড এমআরআই, these are coming up but not yet the thing. So এখন now we look where we are in the era of de-escalation of the treatment, but in oligometastasis we are escalating the treatment. Why? Because we think that we can cure this patient. So now let us have some discussion about the systemic therapy. So if you look at the different consensus guideline, they say the systemic treatment remains the standard of care and should be considered as the initial treatment strategy, regardless of local treatment modality. So whenever we are thinking of oligometastasis, we should not forget or not jump into the radiotherapy or surgery. We should think about the systemic. This is the first message. And if we look at, but there are some issues also. If you look at this EOTC trial, you can see that they are showing that there are some PFS benefit in all the, but when they have gone for this long-term outcome of this trial, they have failed to show any survival benefit. Again, they have done, that was the EPOC trial, popularly known as EPOC trial. In the new EPOC, they have added the cetuximab in KRAS wild group. And again, they have found that adding cetuximab is not giving a good benefit. So if you look at a small series of drugs that has been used in different trial for converting the non-resectable to resectable, and you can see majority have used the 5FU based protocol, and in this new EPOC and this Olivia trial, they have used that cetuximab and bevacizumab. Cetuximab failed to show any promise, but bevacizumab have shown some promise. So challenging is the conversion, but if straightforward, the recommendation for the ESMO consensus is consider if it is excellent case, we can omit, but if it is a good case, perioperative systemic chemotherapy, and it is poor also, we need to think, but it is not a clean-cut case as Pial was, Dr. Tariq was telling, there are many other issues like location, patient comorbidities, and other issues. So here I stop with the systemic portion, that there is some conflicting issues. Say, if you look at the trial, that it is sometimes may be converting, may not be converting. So what is the clean-cut message we can say that when we select to take a help of systemic and when we straightway go for surgery or ablation? Tariq.
So, sorry, the question I'm not quite getting. So is it
suspected oligometastasis? So there is a say 4 centimeter lesion, another 3 centimeter lesion in the liver. Shall we, the surgeon said, I can take it out. So shall we consider to give some systemic and go, or we go straightway? I mean, when to add surgery perioperatively, or when we can avoid, and when to add it with caution?
So if the surgeon cannot take it out, then there is a role of perioperative systemic treatment. And if the surgeon can take it out, if the surgeon able to take out, then straight away surgery we prefer. And also the surgeon prefer, because surgeon doesn't want too much chemotherapy before radiotherapy, before surgery. So if the surgery is possible from the outset, so that is the patient should go for the surgery straight. And if it is if the surgeon cannot take, then perioperative. There is a, and we know that the EPOC, not the new EPOC, the EPOC showed there's a PFS benefit. But now it comes to the systemic treatment, actually what systemic treatment to choose. We know that in the new EPOC, we have just showed the slide that new EPOC showed cetuximab doesn't do any benefit, but actually it is detrimental. Cetuximab showed is actually low PFS, low OS, and mortality also goes up. So, but there are oncologists who are treating the patient with preoperative cetuximab plus FOLFOX or FOLFIRI. I'm not sure about Jahed's view on that. But I think this area is a bit controversial, and different people actually practice differently. Thank you, Kamal bhai.
So Tariq, I intentionally brought up this EPOC because in our culture, sometimes we think more is good. So patient is affluent, whereas wild type, why not chase with more? So if we are thinking of something like this, as you said, new epoch have shown not only survive benefit, it is detrimental. And I understand that if the patient is fit, surgeon is happy, patient is happy, we can go straight away. We don't need to call Zahid. But Zahid, when do we need to call you?
Oh, Kamal bhai, a very interesting topic. So it's very important to consider first thing, is it a synchronous presentation? It is a metachronous presentation, because if it's a synchronous presentation, then think about that there might be more than what we see. Okay, it might be an iceberg. The oligometastatic that we're seeing, it simply could be iceberg. And even in metachronous setting, if it is presenting less than 1 year, then it is still indicating poor biology. And if you think about the molecular profile, again, if you've got a BRAF mutant patient, then you know it is poor prognostic disease. And even if you think about surgery, there is still a high risk of relapse. So there's a lot of things to come into play. But before I make my comment, I need to go back to the EPOCH trial. So we know from the Optimox and Crystal trial that there was a significant benefit of adding cetuximab in the RAS wild-type patients. But the new EPOCH was really disappointing. Okay, so it showed that actually adding cetuximab in potentially operable liver metastasis, it doesn't help. Now, in the EPOCH, when it said that the overall survival was not demonstrated, it was not because the trial failed. The trial was not powered in the first place. The trial only had 300 patients, if I can remember. So it was not statistically powered to demonstrate the overall survival. So we cannot take the overall survival data by face value. And the second thing is that the trial data also suggested the second line treatment when these people progressed had a major play. And also they also suggested that more people died in the chemotherapy arm from non-colorectal cancer related death. Okay, so there are a lot of things to keep in mind. Okay. So again, let's come to the patient that if you have a patient who's got 2-3 liver metastases, it is operable and it is a metachronous presentation, then yes, I agree that there is probably no need of systemic chemotherapy if the surgeons say that we can take it out. But if it is synchronous presentation and any other poor biology, then I would recommend systemic chemotherapy first, but I would not go for cetuximab or panitumumab if it is upfront operable. The only time we might need to think about cetuximab or panitumumab if we're considering conversion therapy. So remember, I think we talked about it before, there's a difference between conversion and neoadjuvant. In neoadjuvant, you know, it is operable, but in conversion, it's borderline operable, and you want to downstage it. And don't forget, in a RAS wild type patient, the combination chemotherapy plus an EGFR target therapy, your response rate is 60 to 65%. Okay, let's come back to another trial, TRIBE trial. There was a TRIBE trial and there's a TRIBE2 trial where there was triplet chemotherapy plus VEGF inhibitor. Now, triplet chemotherapy is not very popular in UK. Tariq Bhai will say, we try to avoid it if we can, but actually the only benefit was shown in younger patients with the people who are borderline operable. The triplet chemotherapy has actually managed to make the tumor operable. So again, that's something to keep in mind. So fundamental question, is there a role of systemic chemotherapy? The answer is yes, but not for everybody.
Thank you, Zahid. We gave chemotherapy and the patient, the lesion disappeared. What I'm going to do?
You still have the primary or the primary out?
The primary out. I mean, it is a metachronous. I mean, it came out.
Okay. If you have no disease, there's nothing to treat. That is the practical approach. If by the way, you have to prove it. So you have to do the MRI, you have to do the PET scan again, and you have to prove that there is no radiological evidence of any residual tumor. And that brings another question, is that the oligometastatic disease definition, characterization, everything is based radiologically. Okay, but now the ctDNA is coming into play. So sooner or later, the oligometastatic disease will not only be defined or characterized by radiology alone. In the future, we'll also look at the molecular profile as well. So, but right now, from the practical point of view, no disease, no treatment. That is the practical approach in UK.
Thank you, Zahid. So I move quickly. I have only one slide on RFA. I have nothing to say much about RFA. RFA is practiced in our country. That's why I brought this slide to tell only one thing. That look at the pattern that if you want to get a good result from RFA, the lesion should be something around 3 centimeter. In our country, we know sometimes we are seeing the patient treated 7, 8, 9 centimeter. Please, for God's sake, RFA is NCCN. If you look at all the guidelines, they are trying to restrict the size of the lesion within 3 centimeter. So now the hot cake is the saber, because we have Tariq with us. So we want to talk about this. Why we are very excited about this saber, because this slide was shown by Sadeka. If you look at the 1 year overall survival, it is 60 to 100%, and in 2 years is near about 60 to 80%, except one series of 38%. So quite exciting. And there are many protocol of saber used. I have taken intentionally the NHS recommendation, because we have both the NHS people with me. So they have given that it can be used 3 to 8 fraction based on, it is always when it is a liver, we need to look at the remaining liver and the OR constraint, then we select the dose. So quick, we look at this publication. It was a 437 patient series where 270 was CRC. And they have shown that the 1 year local control was 93% and 5 years was 73%. And overall survival was 1 year is 88.5%, whereas the 5 years was 37%, which is quite encouraging. And this systemic review published in the same Green Journal, 18 studies and 656 patients. And they have shown that the 67% 1 year local control and 59.3% 2 years, and full 1 year OS was 67% with a very acceptable toxicity. And another meta-analysis, another systemic review of 15 studies have shown that the local control of both hepatic and pulmonary in oligometastatic colorectal cancer is quite encouraging. And SAVOR COMET trial, which Tariq was telling, I'm very excited to talk about this trial. Why? Because you look at the person here, Professor Suresh Senan. It is a multi-center, 10 centers trial in Europe. And Suresh Senan is from Amsterdam and from the Free University, where from our founder, Professor Karim, was the emeritus professor, and he retired from there. So I'm proud to present this paper that this gentleman, Suresh Senan, is representing the center where we have some link to our founder, Professor Karim. So this COMET was the first randomized trial to compare the SAVOR, and then they have shown that addition of SAVOR was giving additional overall survival benefit from 17% to 42%. But it was a phase 2 trial, and there was a challenge of matching the data because we do the CBCT before and after the treatment. There is hardly we do in real-time imaging. So MR-Linac could be a solution, and we are looking for phase 3 data. That's why they are SAVOR COMET 10, that is a phase 3 trial. They are doing the same group and they are recruiting the patient. So here I want to stop and want to have some comment from Tariq about SAVOR in oligomets. Quick comments from Tariq.
Yes, Kamal, SAVOR is emerging, and there will be probably in the future, we'll see more and more patients getting SAVOR. Just to comment on the COMET trial, interesting that you brought Suresh Senan here, and I actually want to have my fellowship with Suresh, and I had some correspondence with him, but then it didn't happen because of my family commitment. And the third author, the Stephen Harrow, is my colleague, and we're trained together. And he had recently moved to Edinburgh now. So I'm very much actually into the COMET trial when it was going on. Interesting, the COMET did not actually include liver metastasis as far as I know. And definitely not in the new COMET. I think the previous COMET also didn't. But they included lung metastasis, and COMET was criticized for many reasons. One is a phase 2. Second is there is a highly skewed towards lung metastasis, because most of the patients actually treated here were lung metastasis. And so it doesn't give any overall picture. So it needs to be tested with a phase 3 trial in the future. So there's a lots of comment and criticism on COMET.
So Tarek, thanks for bringing up. You see, the world is small. Karim sir was in Amsterdam and Suresh was working there. Now another Bangladeshi worked under him. So this is how we complete the circle. And I agree with you, COMET is not a great trial, but COMET is a starting because they had the courage to do the first, the comparison with the standard of care and SABR. And they have taken all the sites, oligomets of all the sites. It was not a focus thing, but they brought up the issue. And with the success of COMET, now people are thinking of, they have started phase 3. And as I showed the data of many systemic analysis and meta-analysis, there are some retrospective review, all are phase 2, small series, but it is convincing that SABR is offering a good data. And now I think now it is included in all the guideline, the SABR as an option for treating oligometastasis. So quickly, so what is the future? Future is the SABR with immunotherapy, because can we overcome the limitation of SABR with immunotherapy? We don't know. So many trials are ongoing, and probably this will give us a solution of that. So, Bangladesh is struggling, but we have some something to discuss, that we have some limited experience of SABR in United Hospital. We have treated a number of patients, our total team, and we have presented in ASTRO 2019, and it was published in Red Journal. And our experience is not bad. We have seen the hepatic metastasis local control 1 year was 75% and OS was 63%. And as it was a mixture of metastatic and primary of different site, but I have pulled the hepatic metastasis, and our experience was quite interesting. So this is just for information that we have started. As for my experience, Evercare and United is doing. I'm sure many more centers are coming up with this, and hopefully very soon, first leap take a long time, but the second jump can be done very quickly. And we are optimistic that with people with the support like you and the new generation, will be bringing up newer technologies very fast. So we are almost at the end. Now I want to ask our colleague Mustafa Aziz Shumon to share quickly a very live case for our discussion. Shumon.
Thank you, Kamal bhai. Let me show my slide. Unfortunately, a patient, Amaderi colleague, uni ekjon doctor, 40 years of age. ওনার 2000
slideshow.
ওকে, দেখা যাচ্ছে?
হ্যাঁ, ওকে, দেখা যাচ্ছে, ফাইন।
এই ভদ্রমহিলা লাস্ট 20th নভেম্বরে 2020 তে তার একটা অপারেশন হয়, তার একটা কমপ্লেক্স রাইট অ্যাডনেক্সাল সিস্ট নিয়ে সে ডায়াগনোসিস করে। তারপরে আমরা ফ্রোজেন সেকশন নিয়ে আমরা বায়োপসি করি। বায়োপসি করার পরে টোটাল অ্যাবডোমিনাল হিস্টেক্টমি উইথ বিএলএসও, এটা দেখা যায় যে পারোপাটি ফাইন্ডিংসে দেখা যায় যে একটা হিউজ গ্রোথ তার একটু সিগময়েড জাংশনে আছে, এবং যেটা ওভারিকে ইনভেড করে। এবং আলটিমেটলি অপারেশনের পরে তার পোস্ট অপারেটিভ যেটা আসে সেটা হচ্ছে অ্যাডেনোকার্সিনোমা কোলন রেক্টোসিগময়েড গ্রোথ। স্টেজিং ছিল T4N2AM1, রাইট ওভারিয়ান ইনভেশন ছিল, এবং পেরিটোনিয়ামের কিছু মেটাস্টাসিস ছিল, যেটা মানে কমপ্লিটলি রিসেক্টেড। জেনেটিক মিউটেশন স্ট্যাটাস KRAS মিউটেটেড, BRAF মিউটেটেড, MSI স্ট্যাটাস নট ডান এট দ্য টাইম। ভদ্রমহিলা এই হিস্ট্রি নিয়ে সে মুম্বাই টাটা মেমোরিয়ালে যায়। যাওয়ার পরে তারা সমস্ত কিছু প্ল্যান আপ করে তারা ক্যাইপক্স উইথ বেভাসিজিমাব তাকে অ্যাডভাইস করে, এবং তার লাস্ট কেমোথেরাপি 19th May 2000, সরি এটা হবে 20th November 2019, তো 20th May লাস্ট ইয়ার এটা তার কেমোথেরাপি কমপ্লিটেড হয়, এবং সে এরপরে সে ফলো আপে ছিল। রিসেন্টলি এই বছরের এই জুন মাসে আমরা যখন ফলো আপ করি, তখন পেট সিটি স্ক্যানে তার দেখা যাচ্ছে যে রাইট প্রিস্যাক্রাল রিজিওনে একটা গ্রোথ, যেটা 2.3 সেন্টিমিটার পেট সিটি স্ক্যানে। আমি পেট সিটি স্ক্যানে ইমেজ দেখাবো। এমআরআই পেলভিসেও বলতেছে একটা সফট টিস্যু গ্রোথ 2.2 সেন্টিমিটার, তার কোলোনোস্কোপি নরমাল, বাট CA19-9 ওয়াজ রাইজ। এটা দেখে সে আমাদের বিভিন্ন জায়গাতে যাচ্ছে এবং তার একটা অপিনিয়ন নিচ্ছে। তাই আমি আজকের এই বোর্ডের অপরচুনিটি নিতে চাই। এটা হচ্ছে যে তার ইনিশিয়াল স্টেজিং যেটা ছিল, এটা ইয়েতে যাওয়ার পরে টাটা মেমোরিয়ালে তারা সবকিছু রিভাইজ করে তারা দেখে যেটা রেক্টোসিগময়েড গ্রোথ, এবং তারা এটা স্টেজ আপ করে T3N2B এবং M1, এবং তারা সমস্ত ইমিউনোহিস্টোকেমিস্ট্রি করে কনফার্ম করে যেটা নট ওভারি, এটা রেক্টোসিগময়েড প্রাইমারি। রিসেন্ট যেটা আমরা দেখছি, রিসেন্ট পেট সিটি স্ক্যানের রিপোর্ট হচ্ছে মেটাবলি অ্যাক্টিভ গ্রোথ, right side of the presacral region with involvement in the wall of the sigmoid colon. বাকি মাইট প্লুরাল ইফিশন বলছে, বাট যদিও সেটা ক্লিনিক্যালি খুব সিগনিফিকেন্ট না। এই হচ্ছে আমাদের পেট সিটির ইমেজ। আমাদের কোলোনোস্কোপি রিপোর্ট বলতেছে যে অ্যানাস্টোমোটিক সাইট নরমাল, সো গ্রোথ নট ইন দ্য কোলন। এমআরআইও বলতেছে একই ধরনের কথা, সবকিছু ম্যাচ 20 মানে মিলিমিটার, রিকারেন্ট দ্য প্যারারেক্টাল রিজন 11 সেন্টিমিটার ফ্রম অ্যানাল ভার্জ about the right lateral pelvic wall. So আমাদের ডিসিশন কি হবে এই রোগীটা সম্বন্ধে? পিয়াল ভাই আর কামাল ভাই।
হ্যাঁ, আমি একটু কমেন্ট করি। Firstly, এটা M1 disease because it is a M1 resected disease initially.
Yes.
Our patient adjuvant যে ট্রিটমেন্টটা পেয়েছে এখানে বেভাসিসিম্যাবটা সবসময় আমরা দেই না, বাট আমি ওখানে খুব একটা কমেন্ট আর করবো না। But এখন যে PET scan যে current situation, there is a recurrence in the PET scan. এবং তো এটা আমরা radiologist comment নেব এটাকে definitely recurrence or whether it could be an abscess. Because post-operatively abscess collection হতে পারে এবং PET scan আমরা জানি যে এটা it can be FDG avid, abscess can be FDG avid. So if it is a recurrence, say if it is a recurrence, not an abscess, and if there are no other disease elsewhere, the next thing would be a surgical resection, if possible. Basically what we call is pelvic exentration, like it's a big surgery to achieve an R1 resection. And if the surgeon thinks that R1 resection is not possible, in that case, there could be role of radiotherapy. And in that case, it could be same like long course chemoradiotherapy, আমরা যেটা দেই, তো সেরকম regime. এবং আমি সেই approach-এ যাবো আর কি। So it will be long course chemoradiotherapy if it is a definitely cancer, not abscess, followed by surgical resection. এবং most likely that এখন যদি surgical resection হয়, it will be an R1 resection, at least, if not R2. That's why long course chemoradiotherapy followed by surgical resection.
Thank you. Thank you.
Okay, Tariq, the patient is a common patient of Shumon and mine. So patient was referred to me, came to me, and my opinion was just like you, that I was suggesting that we should go for a surgery. And she was referred to me by a surgeon, and the surgeon says the area presacral is such that I'm not very sure about the resectability, and I'm not very sure that how much I can take out, on rather how much I'm going to do harm, because it is a very rich area of very nerves and the vessels and everything that there is a presacral, that location, and he was not very comfortable about doing the surgery. So at that time, just for the discussion's sake, Shumon, let me carry it forward, discussion. So she discussed with her primary physician again in TMH, and their recommendation is to go for chemotherapy and then again try for surgery, or if not possible, then radiotherapy. So now we are here. So we know in this type of situation, nobody is wrong. Everybody can make a recommendation with their justification. She is a young doctor, our colleague, and that's why me and Shumon thought that it is a real life challenge that we are facing. And in this type of situation, I think this is a good thing that you said that the location, very much location, we should reconfirm before going. If it is a surgery approach, it's fine. But if you are doing for non-surgery, we should really reconfirm that, yes, it is a metastasis, recurrence or not. As you said, it could be something. 100% confirmation is a must. I think that is a very good take I have taken. And I think what TMH is trying to say that there is a good time of interval. So they have, I think they have recommended. Yes.
Kamal ভাই, এক মিনিট, আমরা প্রথমে অ্যাপ্রোচ করতে চেয়েছিলাম যে আমরা এখান থেকে বায়োপসি করব, বাট হোয়াট উড বি দ্য রুট? ট্রান্সরেক্টাল, কোন অ্যাপ্রোচে আমরা এখান থেকে টিস্যু কালেক্ট করব?
So what sort of operation the patient had? Was it patient had defunctional stoma, I could see that. So was it an APR surgery patient had? Or is it anterior resection?
No, No, it was a TAH BLSO and total resection, and ultimately the allostomy was reverted.
Okay, my TH and BSO, but what happened to the
Initially, it was a gynae surgery with a general surgeon.
Right.
Resection
They have,
anastomy process.
they have done the re-established anastomosis.
Resection. Initially, it was thought that it was ovarian cancer, ovarian malignancy. So initially, the surgeon was gyne oncologist, but when it was opened and it found that it was originated from the colon, so they then taken the help from other colorectal surgeon. So ultimately, it was a radical ovarian surgery was done, and at the same time, it was resection anastomosis. And at the beginning, it was a allostomy was there, and after few months, it was closed.
Okay, but was there any rectal lesion there when they looked at that? When did they do a sigmoidoscopy, and did they find any rectal lesion?
No. At the time, the relation was with the rectosigmoid area, and the margin was positive. You have shown that the margin was positive. I am not sure which margin was noted, but at that time, margin was positive.
Okay. The original question was what the root of the biopsy. The reason I asked, because if it is not an APR, if it is patient has got an access, then probably sigmoidoscopy, and they would they get a biopsy. I know it's not a luminal lesion, but they can get access to the presectoral PET avid area through sigmoidoscopy. The other approach is a percutaneous, but the percutaneous can cause seedling. We know that, and I think that's why probably sigmoidoscopy and then get access to the lesion from there.
Thank you.
And Kamal bhai, is when you mentioned about the chemotherapy, I think nobody knows in this situation what should be the right approach, because it's not evidence on the clinical trial. So yes, chemotherapy upfront can be a correct treatment, but there's two issues here. One is the patient had adjuvant chemotherapy, and adjuvant chemotherapy did not actually stop this recurrence. So it means that probably it is not a much chemosensitive disease, but the interval probably is not too short even. What's the interval from the surgery to the recurrence?
Around 1 month. But the last
1 month.
chemotherapy,
So
1 year. 1 year. Sorry.
1 year. So, and patient had probably 3 to 6 months of chemotherapy. So it means that the interval is short, is nearly 6 months or so. So it means that further chemotherapy may not do any benefit, because if you use the chemotherapy, that will be second line, which could be FOLFIRI. We are talking about plus aflibercept, or patient already had bevacizumab, so probably just the FOLFIRI will go for. And the second line chemotherapy, we know the response rate even lower. So that's why I'm thinking the best chance would be the chemoradiotherapy. But chemotherapy can be an option in other situation, but someone who had adjuvant treatment already and that did not prevent the recurrence. That's why I'm thinking radiotherapy, long course radiotherapy should be an approach once we confirm with the biopsy.
Thank you, Dr. Tariq. I mean, very well said, because exactly the patient received FOLFOX before, CAPOX with bevacizumab. So they have recommended FOLFIRI. And as you said, this situation, nobody is wrong. I mean, everybody have their logic and ground to say, and end of the day, time will speak who was correct. Because if she take chemotherapy and responds, we'll say it was a great decision. It doesn't respond, then say, well, it would be a good to start with chemotherapy. So actually, we don't know. But the bottom line is, surgeons said apparently at the beginning, they're not very happy to do a surgery of this patient. So, I mean, today in the discussion, what I wanted to bring up, oligometastasis is a very encouraging area. Probably in our country, we don't have all the tools, as you said, ready in our hand. But my comment is that we should not forget about it. We should start thinking about, once we see a patient metastatic, we should think, is it an oligo or it's a frank metastasis? Because once it's an oligo, our thought process should be changed. It is no more a palliative treatment. We should take an initiative of intent radical treatment with the attempt to cure. Even we will not be successful, but we will get something between cure and palliation in between. But at the beginning, as a treating physician, if we give up and we treat it as a palliative, we will lose some opportunity. So main message today's discussion is that once there is a chance, we should think about that whether it is oligometastasis or not. Number two, we may not have SABR at every center, but we have some great surgeons in our country. So we should talk with our surgeons whether there is any possibility of doing a surgery. And if all centers are not doing SABR, 1 or 2 or 3 centers are doing, we can take the help of those centers, because even in UK, all centers are not doing everything. Patients are referring from one center to another. So end of the day, because every day it is not, every patient is not oligometastasis. In a whole, month time, maybe 1 or 2 patients will come up. So we can take help of others. Number 3, there is always a use of, we should not forget our good friend systemic treatment. When there is a borderline, we should take it up. And when we are using RFA in our country, especially, I will say that please don't allow your colleague to do a RFA more than a 3 centimeter lesion. End of the day, you are not doing a good to the patient. He or she is losing some money and probably losing some time. By that time, if we have treated some other modalities like radiotherapy or surgery, we could have given a better result. And number 4, there are many encouraging things are coming up, like immunotherapy combination with SABR, not only in colorectal, in many other places, especially in lung, it is doing a huge noise. And I'm thinking that probably immunotherapy in combination with radiotherapy is going to make a game changer in coming days. Probably that will complement with each other. And finally, I intentionally showed the paper of our publication in Astro, just to encourage the juniors that what we have achieved in so many years, you have a milestone set now. So take a target to publish your paper, present your paper in next Astro 2021. I know you can do it. Just you need to take the initiative. And believe me, before publishing it, I thought it was a great big hurdle. But after publishing it, I found it is not that difficult. You just need to do it. So my request to all my juniors, just target that next year you will have a paper in Astro as it is a poster. And once it is a poster, it will be published and you can say, hey, I have a Red Journal publication. And therefrom you will start and you don't know where you will end, because we need to have more Professor Karim, we need to have more Dr. Tarek, who will be not doing some great job in Bangladesh. They will cross the limit of our country and they will be becoming global. So Tarek, thank you very much. Do you want to make some quick last comment?
Firstly, 2 congratulations. One is doing SABR in Bangladesh, and secondly, the publishing in the Red Journal. This is a big achievement, and even many centers in the UK are not doing SABR, and because of many reasons, resources and also red tape problem. The UK, we had lots of red tape problem, like administrative complication. So yeah, it's a big congratulations for doing SABR and the publishing in the Red Journal. So that I didn't realize that actually you are doing so well in Bangladesh. But yes, there's a lot more thing to do. I think we can do together in the future. It's a really good session today. And again, thank you, the presenter Sadeka, for this elaborate presentation. There's many things I think still need to discuss about the oligometastasis, particularly about the lung metastasis in the PALMIC trial, why it was closed early and all these things. So again, this is the area is evolving, so there's a lots of room to discuss in the future again. And thank you for inviting me today. I'm happy to come for the future, and I found it really very useful, helpful, and I enjoyed it a lot. Thank you.
Thank you, Dr. Tarek. We are very happy to have a clinical oncologist, because we have been dealing with many medical oncologists from UK and different part. So it is, in our country perspective, we are doing clinical oncology. So it is always good to have a clinical oncologist so we can talk both the subjects at the same time. So that is, we are so happy, and we will be, hopefully we will be adding you with us. And just for the information, we started SABR in 2013. So we have been doing it for quite a long. And this was published because the team was not comprising of an old man like me. The most important partner of the team was young men like Shumon. So they were the driving force and they were pushing the things forward. And as I told you, believe me, there are many brilliant oncologists in our country, The thing is that they don't know what they can do. They have so much potential. They are, I mean, they need to know that they can do a great job. So we need to give them push or a pull. Either you pull or then I push. We can combinedly pull and push them and bring up in the, the global scenario. And we are very happy that today we had a discussion. As I mentioned, that I don't believe that what we cannot do today, we should not discuss. Global things are moving very fast. We should know about what is we are doing and what is happening in the whole world, because we don't know. Tomorrow morning, we will have the opportunity to do a great job. So if we ignore, because 15 years back, we were said that, well, it is not for our country. Now everything is possible in this country. So we should learn and we should think of everything. We should offer the best. And at least even we don't do, if we write on our prescription about our thought process. So if the patient is going to a neighboring country, the colleague in the neighboring country see my prescription will understand that somebody in Bangladesh was discussing about these possibilities, couldn't do for the limitation of the resource. But if you don't discuss or if you don't say something, then the patient and my colleague will undermine not my ability, but about my knowledge. There is no harm of getting a knowledge. We may have not have the ability or the resources, but there is no border of getting the knowledge. 2021, we should know everything. Maybe we will not do everything. So with these few words, we are already 17 minutes late. I want to congratulate Sadeka, and as Tarek said, oligometastasis is a huge area. If we discuss for 10 such sessions, I think it is not going to end because it is the most evolving subject. I said that 2019, I saw total astro was on oligometastasis, and now they are talking re-saber, retreating the patient. That was the discussion. So they have gone to there. So world is moving really fast on that, and hopefully we will be having some more sessions. And we invite Tarek in advance for next week. We will have a session on anal canal where radiation have a big role. So we will be talking on anal canal at the same time. But Shumon, we are going to shift the time from 3 to 3:30. 3 seems to be a bit early now because the daytime is longer in Bangladesh. After lunchtime, I see many people struggle to join. They join around 3:20, 3:15. So from next week, our time will be 3:30 to 4:30. Tarek, we will be sending you the link and the flyer, but please do join with us next week, and hopefully Zahid will be joining us. Zahid left, I know already, but thanks to Zahid also, he has given his precious time, cutting it off from his family time by joining. That is the commitment that you people are showing, and the amount of support that you are showing is really wonderful because you are sitting in a different environment, but you understand our environment. So bringing you as overseas faculty give us a big room to heartful discussion, because if overseas colleagues sometimes cannot realize our limitations. So you are from this country, you have graduated from here, so you understand you can make a blend of the West and us. So thanks again to all of you. Hi, sir, if you allow, we can finish.
Scientific partner, Kamal bhai.
Yes, I want to thank my scientific partner Acuvida. Without their support, it would not be possible. And thanks for all the scientific partners from A to Z. They have been supporting. Acuvida is supporting for this series. Thanks for their continuous support. Sir.
Okay, thank you, Kamal. Very nice time today. We have 2 faculties from UK. We are our son, they are son of the soil. So my thanks to Dr. Sadeka Sultana, who was quite a good job. Thank you all. We have brought lots of discussion. We are learning many things today. Thank you all very much. Inshallah, we'll meet again next Sunday. Allah Hafiz.
Allah Hafiz. Thank you very much.
Yes,
Goodbye.
inshallah. Assalamu alaikum.
Assalamu alaikum.